Hello, I'm Dr. Keith Henry from the HIV program at Hennepin County Medical Center in Minneapolis and a professor of medicine at the University of Minnesota Medical School in Minneapolis. And it's my task for the next part of an hour to provide an overview of comorbidities in HIV infection on behalf of the Cleveland Clinic Virtual Grand Rounds series. The overview of topics I'll be covering is shown in this slide, highlights being that I'll try to define the term comorbidity. This will be a case-based discussion, be talking about life expectancy in HIV-positive patients compared to the general population, focusing on several key comorbidities, particularly heart disease and cancer, and an approach to managing those key comorbidities. Our case for this discussion is a 51-year-old African-American male who presented to an emergency department with fatigue, swollen lymph nodes, and oral complaints. A rapid HIV test done in the ED was positive, and that was confirmed with a Western blot. His past medical history was remarkable for his last HIV negative test approximately 8 years prior, long-standing hypertension with poor control, long-standing smoking, and no primary care physician. His physical exam noted obesity, elevated blood pressure, diffuse lymphadenopathy, fairly severe gingivitis, and bilateral oral hairy leukoplakia of the tongue. Laboratory evaluation noted a CD4 count of 401. His plasma HIV RNA level was 21,000. Resistance testing noted a K103N mutation, and metabolic assessment was noteworthy for elevated lipids, positive hepatitis B surface antigen test, hepatitis B DNA positivity, hepatitis C antibody negative, and moderate elevations of his liver enzymes. So this patient has a number of active medical problems and highlights a discussion about comorbidities, the definition of which in the context of HIV infection is not clearly delineated. There's numerous definitions, and I've provided 4 definitions from 4 different medical dictionaries here. For example, the first one, a concomitant but unrelated pathological or disease process, often would not fit what we're discussing here because it may be related. HIV may actually relate to some of these other conditions such as cardiovascular disease. Another, perhaps more relevant definition is 2 or more coexisting medical conditions or diseases that are in addition to the initial diagnosis. And the initial diagnosis for an HIV-positive population would be the HIV infection itself, and 2 or more coexisting medical conditions also brings up the concept of polypathology, which I'll be discussing later, involves having 2 or more non-infectious disease-related medical conditions on top of an HIV infection for the purposes of some research studies. And I kind of like that definition. And several of the other definitions just highlight the point that the more medical problems a patient has, the more complex their care is, the more costly it is, and often the higher the billing can be for managing those patients. If you ask the question, what are the most common diseases in the general U.S. population that's aging, this slide lists them in order, with high blood pressure, joint disease, heart disease, and cancer being the most common diseases. Often, the risk for those diseases is related somewhat to modifiable lifestyle factors, and the prevalence of lifestyle factors is listed at the bottom, such as lack of adequate exercise in 1/3 of the population, obesity in at least 1/3 of the population, and smoking cigarettes in about 1/5 of the population. If you ask the question, well, what serious consequences do these comorbidities have, this slide lists the most common causes of death in the United States for the year 2009, with heart disease being the most common cause of death and cancer being the second most common cause of death. And those 2 conditions, heart disease and cancer, are becoming the most important comorbidities in HIV-infected patients receiving adequate HIV treatment and aging. and will be the focus of much of the remaining part of this discussion. So comorbidities are important in HIV-positive patients because they're now living longer with access to therapy. So they start having similar problems to the general population as they have less AIDS-related events and an increasing rate of non-AIDS-related events. The risk factors for many comorbidities may actually be higher in HIV-positive populations, and key examples of that would be increased rates of depression, smoking, drug abuse, co-infection with key co-pathogens such as human papillomavirus, hepatitis B and C, and poverty. And an ongoing debated question is whether HIV infection itself or some effects of antiretroviral therapy may also independently increase the risk for comorbidities, and we'll be discussing that further later in this discussion. If I were to list the key comorbidities in aging HIV-positive patients who are surviving long-term, this would be the conditions I would highlight: cardiovascular disease, cancer risk, renal disease, bone health, liver status, mental health status, and chemical dependency. A good example of the issues that come up is shown in this slide, which is a little busy and is from a study done in Italy where a population of HIV-positive patients was compared to a matched population of HIV-negative patients, or the controls. So for the sake of brevity in this discussion, I'm just going to focus on the group that's ages 51 to 60, which is the third column of each of the two sets of columns, and looks at the rate at which there's no comorbidity in that age group. And for the HIV positives, that rate of no comorbidity was 42%, and in the controls, it was 65%. And then if you look at the rates of what's termed polypathology, which is, again, for this study, 2 or more non-infectious disease-related medical conditions on top of HIV, or polypathology, the rate of polypathology for this age range was 20% in the HIV-positive population and 7% in the HIV-negative population, suggesting a much higher rate in HIV-positives. And in fact, this study concluded that the rate of comorbidities appeared to be about equivalent for somebody who's 10 years older in the HIV-negative control population, and that comorbidity or polypathology risk was higher in those patients that had a CD4 count at some point less than 200. For me, the first 15 years or so of the epidemic, the focus was on AIDS-related morbidity and mortality. It took quite a while to fully appreciate the evolving importance of non-AIDS-related medical conditions, and I first really appreciated that from data presented in 2006 from the DAD study, which is a key finding is shown here. In this graph, as one goes from right to left, you have decreasing CD4 counts, and the lines shown here in color represent the relative risk of death by type of condition. One would expect the risk for HIV-related death would go up with the lower CD4 count. That's shown in red, but the surprising thing here was that the risk for liver-related death, heart disease-related death, and malignancies that were not from an age-defining cancer also went up, showing that these conditions are also quite important and may be related to the degree of immune deficiency. So in the HAART era, the life expectancy of our patients is steadily improving. In some studies, particularly those from Europe, among persons doing well on therapy with suppressed virus and CD4 counts often above 500, estimates are that their life expectancy will be getting close to those of HIV-negative persons. For North America, a recent estimate of life expectancy was presented at the retrovirus meeting this year in Seattle from the NA Accord group. And this shows on the left side with the bar graphs the anticipated additional life expectancy for the average 20-year-old by time of diagnosis. And you can see over time that life expectancy is going up. And for the purposes of illustration, if you look on the table on the right, for a 20-year-old male in the general population who's HIV negative, the additional life expectancy was 55, and the estimated life expectancy for the ARTs HIV positive male who's age 20 was 41 years. So still a difference, but overall that would add up to a life expectancy of over 60 years. If you then start trying to zero in on what are the causes of death in the modern HAART era, there's a number of studies that illustrate how things are changing. This slide is from the ART collaboration and basically shows that through 2006, for the last decade, about 50% of the deaths occurring were from AIDS-related conditions, and 50% were from non-AIDS-related conditions. In the next slide from the DAD study, with a data set extending through most of 2007, AIDS-related conditions made up about 30% of the deaths, and non-AIDS conditions made up the majority of the deaths, with liver-related deaths, non-AIDS cancers, and cardiovascular disease being the three most common non-AIDS-related causes of death. So back to our case patient. The question is, should he be started now on antiretroviral therapy? And answers that are provided here are, and only one is correct, yes, because he has oral hairy leukoplakia, which is age-defining, no, because his risk for AIDS is low, and he has other pressing health problems. Yes, the CD4 count is less than 500, and that is an indication for ART, and he needs treatment for his hepatitis B. And lastly, uncertain, because there's no consensus for a patient with a CD4 count at about 400. The right answer for this case would be that his CD4 count less than 500 is an indication for therapy, and he does need treatment for hepatitis B. So the rationale for using therapy in broader populations has been updated in the spring of 2012 version of the U.S. Department of Health and Human Services treatment recommendations, and part of their rationale is repeated here. Important to the discussion of comorbidities is that a reduction in AIDS and non-AIDS associated morbidity and mortality is expected with earlier therapy. An explanation for that might be a reduction in HIV-associated inflammation and associated complications, though that's not absolutely proven. But the panel did strongly feel that therapy was indicated for patients with low CD4 counts and symptoms, and at least moderately indicated for all patients. Since therapy is becoming more effective and well tolerated, reasons to avoid therapy have been diminishing. The specific level of recommendations for starting therapy by CD4 count are summarized here, with the strength of the recommendation increasing with the lower the CD4 count. So, for example, patients with CD4 counts less than 350, a strong recommendation to treat based on randomized clinical trials. The newer aspect of the recommendations are for those patients with CD4 counts greater than 500. There's a moderate recommendation based on expert opinion, and at the lower part of this slide are those conditions that therapy is recommended for regardless of the CD4 count, with a notable new addition is that age greater than 50 is an important issue for a higher percent of our patients all the time, is an indication, at least at the moderate level, for starting therapy. So what about aging and HIV infection? Well, the epidemiology of the population in the U.S. and among HIV-positive patients somewhat overlaps and is causing what I call a mini baby boom phenomenon, whereby a significant number of baby boomers became HIV-infected in the first decade or so of the epidemic, and then as they've survived by another 5 or so years, nearly 50% of all the HIV-infected patients in the United States will be greater than 50 years old, and thus would expect to have increasing comorbidities with their aging. and that fact is reflected in the new DHS guidelines, which has a new section on aging and HIV infection. So if we focus on the comorbidity of cardiovascular disease, that association between HIV and cardiovascular disease has passed through a number of historic phases. In the pre-HAART era, the focus was very much on age-defining events and little awareness of cardiovascular events not related to AIDS itself. There was some cardiac concerns related to infections of the heart directly and possibly myopathy from some of the nucleoside reverse transcriptase agents. In the early HAART era, there was reports of a possible increase in coronary artery disease and some initial linkage to protease inhibitors. And now in the modern era, there's awareness that HIV infection can impact lipid levels. That's from the MAX study, and may increase the risk for cardiovascular disease from the SMART study. And there's also awareness that some particular antiretrovirals may also contribute to the risk for cardiovascular disease, for example, from the DAD study, and I'll talk more about that in a moment. If you look specifically at cardiovascular disease in New York City, a fairly recent paper examined the death certificates of almost 70,000 HIV-positive residents of New York City and found that deaths due to non-AIDS causes increased from around 20% to over 26% over a 6 or 7 year period, and that for persons greater than 55 years old, heart disease had become the leading cause of death in HIV-positive patients in New York City. The DAD study recently published an analysis of risk factors associated with cardiovascular disease-related mortality and found that some of the standard risk factors such as diabetes, hypertension, smoking, and increased age increased the risk for cardiovascular-related death. But the HIV-specific aspect was that lower CD4 counts were also associated with a higher risk of death, indirectly supporting earlier initiation of therapy to avoid a lower CD4 nadir. So why might the HIV-positive patients have increased cardiovascular risk? Well, right off the start, there are clear data suggesting that there are higher rates of some standard risk factors among many populations of HIV-positive patients, particularly smoking, but also metabolic abnormalities, hepatitis C co-infection, hypertension. Many patients have poor access to primary care, so their comorbidities are not well managed. The issue of whether HIV is a separate risk factor remains a hot topic. It's not yet officially recognized as a coronary artery disease risk equivalent in risk calculator tools, and we'll have to see over the next decade whether that changes. And again, some antiretroviral medications may also add further to risk for cardiovascular disease. Dyslipidemia has been a hot topic in the field for over a decade. Study from the MAX cohort showed that HIV infection itself decreases what's felt to be the protective HDL levels and increases triglycerides. Some of the older protease inhibitor based regimens seem to have more lipid problems, not seen so much in some of the newer protease inhibitor-based regimens using atazanavir, darunavir. Efavirenz appears to have more lipid problems than iverapine. Raltegravir appears to have little lipid effect. So in the population that you're looking at may have different responses to drugs. Usually treatment-naive patients have less lipid problems than treatment-experienced patients. You also have fat distribution problems that may or may not be related directly to the plasma lipid problems, and all of this is added up to an increased risk for the metabolic syndrome in many HIV-positive populations. So if you try to look at how all these factors impact cardiovascular disease risk, you have HIV infection possibly increasing inflammation, and through other mechanisms increasing risk. You have antiretroviral therapy maybe minimizing that, but in some cases having some direct effects on the cardiovascular risk themselves. And then you have the traditional risk factors all feeding in to the degree of cardiovascular disease risk, which is often hard to sort out even in large populations of HIV negatives. So it's not surprising that this has been sometimes difficult to tease out the most important factors and the explanations for them in HIV-positive patients. Now, the study that probably most clearly suggested that being on therapy with antiretroviral agents decreased the risk for cardiovascular disease was the SMART study. You may remember there was a study that took patients with higher CD4 cell counts and randomized those patients to either continuous therapy or interrupted therapy based on CD4 counts. And about the time the study fully enrolled, the Data Safety Monitoring Board closed the study because there was increased event rates in those on interrupted therapy, and those rates of events included AIDS-related events, but also non-AIDS events, as shown in one of the tables from the initial publication from the SMART study, where there increased rates of non-fatal cardiovascular disease events and also combined cardiovascular, liver, and renal events. And it really brought a lot of attention to these non-AIDS events could possibly be related to HIV replication that's not being controlled. Screening recommendations for cardiovascular and metabolic disease are summarized briefly here. Lipids should be checked and glucose at baseline, at the start of therapy, and perhaps annually. Using a cardiovascular risk assessment tool such as the Framingham risk calculator is useful, often at baseline, start of therapy, and annually. Checking biologic parameters such as blood pressure and body weight is also useful, and screening for substance abuse, particularly alcohol, is also viewed to be very important. So, concluding the discussion on HIV and the heart and comorbidities, this is going to be more of a problem with aging patients. Cardiovascular disease has emerged as a leading cause of death in HIV-positive patients as they've aged. The risk may be higher than the general population due to a high rate of standard risk factors and perhaps HIV infection-related immune activation and inflammation, and possibly from some effects of specific drugs. Effective therapy with HIV suppression and CD4 recovery is likely to decrease the risk of cardiovascular disease. That still needs to be further evaluated. Focus on standard risk factors is warranted, and cardiovascular disease is likely to remain the focus for HIV research for the next several decades. Now, moving to the second big category of comorbidities of cancer, the risk appears to be increased in HIV-positive patients, but more data is needed. It remains unclear if persistent immune abnormalities from HIV will increase the cancer risk as time goes on. There's clearly an increased risk for cancers associated with smoking, and there's also appears to be an increased risk for cancer associated with co-pathogens, anal cancer due to HPV infection, and liver cancer due to hepatitis viruses. This slide looks at the trends in non-AIDS cancers in the U.S. over approximately a 15-year period, and the AIDS-defining cancers equal in total the non-AIDS-defining cancers, but over time, the annual rate for AIDS-defining cancers has been decreasing, and the annual rate for non-AIDS-defining cancers has been increasing. So the trend is that non-AIDS-defining cancers will become predominant in the future. If you ask which specific cancers are we talking about, recent data presented at the retrovirus meeting in Seattle from the DAD study looked at the events or risks for specific cancers, and three cancers really stood out. Anal cancer risk was high, felt to be due to HPV virus. Hodgkin's lymphoma risk was high, and lung cancer, as we discussed, often related to cigarette smoking. From the DAD study, they looked at what were the risk factors for mortality from non-AIDS cancers in their cohort, and a low body weight, smoking, and increased age, not surprisingly, were associated with non-AIDS cancer deaths. And once again, a lower CD4 count was associated with a higher risk of death. Again, indirect evidence that starting therapy before the CD4 count falls might blunt risk as time goes on for non-AIDS HIV-related cancer deaths. So screening recommendations for cancer in HIV-positive patients generally follow standard American Cancer Society and Department of Health and Human Services guidelines. Yearly intervals are recommended for cervical and possibly anal pap tests. Breast exams and prostate exams is recommended, and periodically liver function tests, alpha-fetoprotein, and liver ultrasound if a patient is hepatitis B and C co-infected, and colonoscopy or fecal blood tests for colon cancer screening, and sunscreen and avoidance of UV light to minimize the risk for skin cancer. So back to our case, the question is, should we start him on a particular regimen? He actually was mulling over in his own mind whether he wanted to go on therapy. So in the meantime, he was placed on low-dose aspirin and lisinopril to partly address some of his cardiovascular risk. And then 4 choices are shown here for his regimen: Kaletra and Combivir, Atripla, boosted atazanavir, and Truvada or Indinavir plus Truvada. If you ask what are the preferred regimens updated for the 2012 version of the DHS guidelines, they're summarized in this table based on categories of the anchoring drugs, non-nucleoside drugs, protease inhibitor-based or integrase-based, or for pregnant women. So a high percent of initial regimens in the United States tend to be from those listings. Again, because this patient has cardiovascular disease, when asked the question, would any specific drug increase his risk, 2 nucleoside drugs, abacavir and DDI, and 2 protease inhibitors, Indinavir and Lopinavir, have been associated with an increased risk for MIs in some studies. And for abacavir, that risk has not been consistently found, and the mechanism is unclear. There's been no risk for increased MI from atazanavir from recent studies, and ACTG 5202 did find, somewhat to my surprise, that there are increased levels of total cholesterol and LDL with the efavirenz compared to the boosted atazanavir arm, whereas the boosted atazanavir arm had more of an effect on triglycerides. So given that history of what various drugs can do to cardiovascular risk and lipids, and knowing what the recommended regimens are, this patient was started on choice number 3, the boosted atazanavir and tenofovir emtricitabine. So over a 3-month period, he had a modest increase with a CD4 count. His plasma HIV RNA level decreased to below the detection limit. He gained 5 pounds. His hepatitis B DNA level dropped to below the detection limit, and his liver enzymes improved. His blood pressure remained slightly elevated, and he had some modest increases in his lipid levels. For example, the LDL went up slightly, as did the HDL. So because cardiovascular disease appears to be a major issue for this patient with his smoking and blood pressure and lipids, a useful tool is to assess the actual risk is the Framingham risk equation, which is duplicated here. And at the bottom corner of the slide is a website where you can access this, and I often have used this to go over what a risk is for a particular patient and to model how things might change with various interventions. The question comes up, is this reflect the actual risk in HIV-positive patients? That study has been done for the DAD cohort, where they looked at the actual observed rates of heart attacks in blue and the estimated risk from the Framingham risk score in orange, and one can see that the risk was somewhat underestimated by the Framingham risk score. Because smoking is such an important risk factor, it's important to be able to try to convince patients of the importance of stopping smoking. And the DAD studies provided some data on that important topic, looking at the risk of a heart attack for those smokers being about 3.4 times higher than in non-smokers. And then importantly, in the right side of the graph, as time since the last smoked increases, there's a drifting down of the risk for a heart attack over time, and one would hope that by years 4 or 5 out, it will start becoming close to that risk for a heart attack of non-smokers. So it takes a while to get there, but it appears that the cardiovascular benefit or payoff can be observed. Often, one considers adding a lipid-lowering agent to manage the lipid levels that are often increased in our patients. And one of the more useful places I look for guidance is the European AIDS Clinical Society recommendations, and the key table is shown here. There's a lot of drug interactions, and again, I'll just point out, for example, that often I see outside consultants, often for insurance purposes, using simvastatin as the initial statin, and that's contraindicated in patients on protease inhibitors, for example. So it's important to review drug interaction issues, and often having a pharmacist who's knowledgeable about this can be key. Since HIV-positive patients on treatment who are aging have many potential comorbidities, neither the standard HIV surrogate markers or the Framingham score, which looks at just heart disease, really captures a global picture of health risk. So a new useful tool looking at mortality in HIV-positive patients that I have found used in clinic now is the VA cohort study index. And I've provided in this slide the web sites to access it for the PC or for an iPhone. For our patient, this is what that index calculation looks like. And I've plugged in his recent labs, including his response to therapy, and I'll point out that it has some key demographic variables, some key HIV-related surrogate markers, bone marrow indices, liver indices, renal and hepatitis C-related indices. So it captures a lot of in-organ damage that can be impacted by such things as high blood pressure or diabetes, for example. And for our patient, the index came out at 47, which, despite the fact that we might be patting ourselves on the back for how well he's doing HIV-wise, gives him an expected mortality for the next 5 years of 25%. And that is a figure that may not sink in for patients, and so the website does have this graphic that kind of helps emphasize either to the providers or to patients what we're talking about, that basically 1 in 5 patients with his current laboratory parameters and demographics would be predicted to be dead in 5 years, even with good control of his HIV, indicating that a lot of work needs to be done with his comorbidities. So given that, the patient was referred to a smoking cessation clinic. Now, success rates for treatment of smoking are often quite low in many populations, and in HIV-positive population, the success rate at 1 year was 9% in one intervention study. He's also referred for lipid and weight management to a dietitian. His Framingham risk was calculated at 20%, which is high. So then we modeled with the patient there, if we got his blood pressure under control and added a statin with a 30% decrease in his cholesterol, then his Framingham risk score would improve to 10% risk. On the other hand, if no statin was used but he stopped smoking and we controlled his blood pressure, then his risk score would be 7%, showing really the importance of the smoking. So with all of this in mind, the patient decided to defer adding another drug, but realizes they'll be dealing with these issues in the years ahead if we're to maximize his chances for a long-term survival. So taking kind of now a global overview on the main issues pertaining to the management of comorbidities in our patients with HIV who are aging, first question is who will provide care? This winds up being complicated. Another question is, do standard primary care guidelines apply to HIV-positive patients? There is some help out there on this issue, at least some guidelines. The DHHS has a guide for HIV/AIDS clinical care available on the web. The HIV Medical Association has guidelines for primary care, kidney disease, and dyslipidemia. And the American Association of HIV Medicine has treatment strategies for older HIV patients recently published on the web with the reference provided there. Though the question is, will standard guidelines in HIV-positive patients have the same risk-benefit ratios that they do in the general population? You quickly can run into polypharmacy issues as well as cost issues. And I think studies are going to have to be done to what care is really most needed when there's a lot of competing issues. So my attempts at answering some key questions on the topic of comorbidities and HIV infection are summarized here. Do comorbidities occur in HIV-positive patients? The answer is an emphatic yes. Are comorbidities important in HIV-positive patients? The answer is also yes. They will become, if not already, the major cause of disease and death in patients with access to antiretroviral therapy. Are they more common in HIV-positive patients? Likely yes, but more research is needed with good comparison groups. Are comorbidities worse when they occur in HIV-positive patients? Likely yes, but again, more data is needed. And a very important question is, does early treatment with antiretroviral therapy decrease the risk for comorbidities? And that answer is likely yes, but more research is needed. For example, the START trial, which is still enrolling, is looking at starting patients with CD4 counts above 500 or deferring therapy and looking at their global health outcomes over a 5-year period. And then finally, and most importantly, will the primary care needs of HIV-infected patients challenge the U.S. healthcare system? That, I'm sure the answer is yes, and I have concerns about who will provide that care and who will pay for the primary care, both in the general population, unfortunately, and in our long-term surviving HIV-positive patients. With that, I'm concluding my attempt at providing an overview for the topic of comorbidities and HIV infection. Thank you very much.
Thank you, Dr. Henry, for that excellent presentation to help us focus better on these multiple HIV co-related morbidities. With that in mind, please complete the questionnaires at the end and the appropriate CME work that is necessary in order for you to receive credit for your efforts today. We hope that this presentation will be of use to you in your clinical work. We look forward to having you with us on future presentations. Thank you very much.